On today's episode of Vital Viewpoints on Healthcare, we are joined by two managing directors from HMA's delivery systems practice, Robert Ross and Warren Brodine. Together, they bring deep experience shaping care across hospitals, physician practices, federally qualified health centers, and safety net systems, showing us that healthcare delivery is about much more than hospitals alone. Rob Ross has led hospitals through financial turnarounds, mergers, and system integration, all while improving patient experience and quality of care. His leadership spans from Montefiore St. Luke's Cornwall Hospital in New York to MedStar Washington Hospital Center in D.C., where he advanced patient safety, streamlined operations, and strengthened behavioral health services. Warren brings decades of experience guiding FQHCs, IPAs, and safety net systems. Warren has helped design whole-person care models that address social determinants of health, achieving major cost savings while improving outcomes and engagement. Warren also serves as a national voice for payment reform. Together, Rob and Warren bring perspectives from hospitals and community-based care, the two parts of the system that must work in concert to create sustainable and patient-centered healthcare. Thank you both for joining us.
Great to be with you, Jen.
Thanks for having us, Jen.
So let's start with this concept of interdependence. Traditionally, we think of health systems as hospitals and doctors' offices and community care as clinics and other sources of care in the community. But altogether, our total healthcare delivery system includes all that and more, places where people get care, behavioral health care, even in jails. So when we think about the broader definition of our care delivery system, how does this help frame our national discussion around healthcare access?
The way I look at it, and many people look at it as far as access, it's really having the right care in the right location at the right price that can be easily accessed by the patient. And if we really focus around that, we start to look at the definition of healthcare access throughout the United States and where the most appropriate place for patients to access our care. We all tend to look through our lenses. You'll hear through our conversation, and Warren and I joke with each other on a regular basis, being hospital-centric versus being clinic and health center-centric. And so we tend to look through our lenses, but if we can pull the lens back and really look at from the whole system and really look at really what's the right location and the right cost and the right care, I think we can start to frame the conversation better.
Well, we'll start off with a point of, what do they call it, violent agreement, the right care at the right place with the right provider at the right time. Jen, when I think about what is going to make healthcare more sustainable, leaning into the no wrong door approach to healthcare is really the right answer. Wherever a patient is poised and ready to receive the care that they need, then that's the right place for them to get the care. And marrying this concept of the care that the patient needs in the setting that is appropriate at the right price point across all types of payers, whether that's the patient paying out of his own pocket, or an insurer, or some kind of other risk-bearing organization that is managing the total spend of the healthcare in a way that's culturally competent and appropriate and accessible to the patient, are really the pieces that come together to get the care delivered and get the outcomes that we need.
So people talk a lot about, meet people where they are. And I think that's really what you're talking about. But, we have a very fragmented system, and we know that. And so, how do you bring those pieces together? You talked about payment. You talked about, no wrong door. If you had a blank slate, what would an ideal kind of partnership look like between health systems and community health providers?
The right blank slate in this environment, to me, is one where the incentives are actually correctly aligned, to where everybody has a piece of the action, so to speak, in terms of managing total cost of care, so that all providers of all types are rowing in the same direction to maximize outcomes while minimizing costs and making sure that the patient remains at the center of it. As long as we have fractured incentive systems and fractured payments where everybody has the ability to sort of go in and negotiate for their own bigger slice of the pie, the more we're going to have providers sort of tackling each other to get to the patients rather than being truly focused on meeting all those right care, right place, right time, right cost kind of things that Rob and I laid out. Rob, what would you change?
From my experience and for what we've seen both in my experience prior to consulting and in consulting, it's really to sit down and understand the organizational missions of both and acknowledge that they're different. There are different payment structures and different funding mechanisms for both. There's different organizational missions for both. And so therefore they're coming at the healthcare system from different perspectives. Neither one is right nor wrong. And understanding that is really the foundation to building that relationship. I'll give an example from my career of that. There was an FQHC in my community, and I was running a safety net community hospital, and we kept going to the FQHC saying, why are your patients showing up in the emergency department? And the FQHC was saying, why are you taking all our patients in the emergency department? And what we ended up doing after we sat down and really discussed it is agreed that we would put a case manager from the FQHC in the emergency department. And that began to help both of us understand why patients were choosing care in the emergency department, which may or may not have been appropriate, or the FQHC, which may or may not have been appropriate, and then we can adjust our services appropriately. And so I think it really is sitting down, understanding the perspective of each, and then focusing on what's best for the patient.
You were just talking about a safety net hospital and an FQHC and that sort of, interrelationship. There's probably the same type of a conversation between, a general physician practice and a non-safety net hospital. But how do we even think of safety net these days? I mean, is it kind of segmented by type of reimbursement, lack of reimbursement? Some of the safety net hospitals and the FQHCs they're getting their funding differently. And so you don't necessarily have to have insurance. But I just wonder how we think about safety net these days as incentives kind of start to meld and merge and evolve. And, how does that lead us to think about overall sustainability between these systems?
If we had to characterize the safety net today, what you have is it's a mission commitment to taking care of individuals and an organizing business principle that taking care of folks who are recipients of Medicaid and analogous types of coverage, as well as care to the uninsured and underinsured, is really a hallmark of that. And a true safety net institution has that at its center, not at its margin, and is organized around making sure that the entire community gets care and not just individual patients. There's no one definition of safety net to me, but there are some characteristics that you find across the safety net.
Well, that's interesting when you think about the population health, right? In theory, are non-safety net, quote unquote, hospitals leaning into that space too, right? I just wonder how blurry those lines are.
The lines are very blurry, and the definition of safety net is, to Warren's point, depends who you ask and when you ask it. You'll get different definitions, and there's formal definitions and informal definitions, and they all differ. But I think Warren described it perfectly. It's core to the mission of a safety net to serve a population that may be underserved or may have challenges in getting access to care for a variety of reasons. It could be insurance or lack of it, but there could be other barriers to care. And a safety net at its core is seeking to reduce those barriers and allowing for easier access to care for the entire community that's served.
Yeah. And I feel like that's sort of like culturally specific, depending on what community they're serving, right? There are different barriers to care in different, communities. I mean, one could argue that many people with even decent insurance have some barriers to care. And I think it's interesting just to think about what sustainability looks like in a time right now. We're recording this when, we have lots of potential cuts coming. So maybe let's talk about financial stability a little bit and payer mix changes that we're facing. So, Rob, you've led hospitals through these types of financial turnarounds. Talk a little bit about, payer mix, different revenue streams, how does that all play a role in financial sustainability and specifically right now about Medicaid cuts, right? Some people, I think Medicaid cuts affect only people who have Medicaid. We know that's not the case. So talk a little bit about kind of payer mix and what that means for overall sustainability for any of these organizations.
So, I mean, the first question that anybody asks a hospital when they're talking about their financials, they'll ask the first question being payer mix. And that's being the core to a hospital's sustainability is what's its payer mix? How much of it is commercial, which is a higher rate of pay? And if the percentage of commercial is too low, they're going to struggle to have financial sustainability if they rely too much on Medicaid, which is generally a lower pay, or Medicare is middle of the road, and then also the percent that are uninsured. So payer mix is the key. We're seeing in hospitals kind of a widening. So the hospitals that have been doing really well are performing better, and there's a larger gap. And then there's the hospitals that are performing poorly, and that gap is growing due primarily to payer mix. So for a hospital to be sustainable, there's two key levers, and it's the way our system works. Hospitals drive their bottom line through payer mix, having more lucrative commercial insurance contracts, and limiting to the degree possible for the community they serve, Medicaid, uninsured, and Medicare. And the other is the complexity of care. The more procedures that are done, surgical or cardiac procedures, the higher the reimbursement, the more sustainable. So if you look at those two levers for a hospital, that's really where you see financial sustainability. And as we advise hospitals, we look at payer mix, we look at what their service mix is, and see where they can make gains in that in the future so they can remain sustainable.
So when we think about, Medicaid cuts in light of that, Medicaid typically reimburses at a lower level, as you point out, compared to other payer types. And so, hospitals are kind of in the conundrum, right, where they've obviously want to maximize your commercial reimbursement, but also, there's been a lot less uncompensated care with Medicaid expansion. So how do you see these Medicaid cuts really affecting hospital operations for everybody? Or do you?
Significantly. The Medicaid cuts will have and it comes in two forms. One is reducing the number of people who are eligible for Medicaid. So you'll shift more people from Medicaid to uninsured, which puts pressure on a hospital's bottom line, as well as clinically, which I'll talk about in a moment. And the other is the cuts that are coming in a couple of years to what they call state-directed payments and provider taxes, and that going down. So the amount that hospitals are being reimbursed for each episode of care will get reduced. So there's pressure on both sides, fewer Medicaid covered patients and more uninsured, which generally means that you're providing free care or almost free care. And then also Medicaid reimbursement you're currently receiving is going to go down. So there's going to be, at least as the laws are written right now and what HR 1 has, it'll have a significant impact on hospitals. And those hospitals that I mentioned before that are already struggling will be even more of an issue for them.
So when you think about the patients that sort of drop out of those systems, Warren, do you see, is that when FQHCs get more busy? Do those patients find their way to clinics more often?
Because of the way that community health centers, FQHCs, are compensated for Medicaid and Medicare, the hospital's worst payer is the FQHC's best payer. And so, because the systems were constituted to do this population health in the community for low-income individuals, there's a special reimbursement mechanism on a prospective payment basis that exists for community health centers, FQHCs, whereby all the costs, theoretically, of providing these extra social supports to reach patients are compensated through that rate. So the answer to your question is kind of, it depends, because the level of care that's offered in an emergency department or in an inpatient setting is not typically replicated within an FQHC setting. Typically speaking, what we have to handle in all of this is that right care in the right place at the right time question that Rob and I kicked off this conversation with. And so part of the challenge that Rob is referring to is that because we have a fractured healthcare system, people seek care in hospitals that they should seek in community health center environments. And it's very costly to provide that care within a hospital setting, and it's a better supported patient experience and social determinants lift in a community-based setting. So part of this coming together, and payer mix does play a role in this, but part of this coming together is around getting the system to properly and appropriately apportion out the care to the right location so that the right payment is following the right set of services. So, anyone who's had an ED visit, you get evaluated for a lot of different body systems and you get a lot of tests and a lot of x-rays. And if you think about it, sometimes one of the biggest challenges to the healthcare system today from a financing perspective is people seeking outpatient, regular doctor office kind of care in the hospital with all the costs that brings along with it. So, while yes, hospitals get strapped and stretched, the nature of the beast in a hospital is that they're always there and available. So people continue to seek care there, even though it's more expensive. So I'd amend your question. The clinic environment should get busier, but whether or not it does is a matter of a question. And this is really the crux of our work. Rob and I are trying to organize systems of care in communities and with communities to help them get to that right care at the right place at the right time. Nirvana that we're looking forward to living in. I want to address, though, the point of payer mix, too, because what ends up happening is, everybody is a business here. So everyone is focusing on their income stream and their bottom line. And they've got baskets of services and community benefits and participation that everyone's looking for the healthcare sector to provide. And hospitals seek, as Rob pointed out, they seek the largest and biggest payer mix that they can get and sort of market share within that commercial environment. It does have an interesting ripple effect on care for uninsured and for others. So while no hospital can limit, say, for instance, labor and delivery by payer mix, right? That's the EMTALA Act. And if somebody's in active labor, then they have to be cared for. And that's a wonderful feature of our system that we need to preserve. But you'll see hospitals rightly sort of forge partnerships that push up that commercial mix of their cases. If their dream state is that they're full of commercial patients, so can't accept Medicare or Medicaid uninsured because they just don't have any room, and we allow things to sort out that way within our communities. So if I really saw this through to the end, we would have a lot of ability to sort of work as a community of care and a community of providers to make sure that we're helping people access the care that they need at the right setting so that we're using the dollars in the most effective way possible, so that we're doing primary care in a primary care setting, that we're helping patients address their social factors of health within that primary setting, and frankly, not doing a $200 outpatient visit in a $1,200 hospital setting. And that's really the bottom line.
And just to add on to that, Warren, and you talked about EMTALA being a feature is also a bug of the system, because that is truly the last safety net. Hospitals do have to, by law, accept every patient in the emergency department. And just like you said, it's both clinically and certainly from a cost standpoint, it's not the ideal location of care. But where the hospitals and the FQHCs can work together is exactly what you said, bringing them together, having primary care being seen by primary care providers in the FQHC, but also easing the access and the transition when a patient needs that specialized care, to have that ease of access that the hospital is and the providers at the hospital and the specialists, that patient can have that ease of transition and access. We've all navigated the system and the work referrals. It is difficult even for us to understand the system. Nevertheless, people who are less savvy with the system. So it's incumbent upon us as providers, whatever part of the system we're on, is to reduce the friction in moving through the system.
The greatest features often are the biggest bugs in any system. We need to emphasize the features and de-emphasize the bug wherever we possibly can. Really successful communities and communities of care are doing strong patient and community education about how to see care at the right level and at the right time, and making services available, around the clock. through telemedicine and some of those things. The COVID pandemic did one amazing thing in the Medicare and Medicaid market, which was actually equalize it to the commercial market in terms of telemedicine access. And I mean, as a person who's been covered by private commercial insurance for my entire life, I have always had telemedicine access. How many of us have picked up the phone and called our doctors and gotten a prescription called in? So that's par for the course, right? In almost every commercial paying system and in every capitated system where providers are allowed to work at the top of their license, and they don't need to bring someone in for a prescription if they don't need to. And but those systems didn't exist, and there was no support for that in Medicare and Medicaid prior to the COVID pandemic. And now we're speaking on a day where it's in limbo because of the shutdown. September 30th was the last day, and it has not been reauthorized. So telemedicine flexibilities are currently in a state of flux. And I know providers are continuing to serve people with telemedicine, but those are some of the ways in which we can permanently improve the system by having really great call a doc lines and teledoc lines so that all of our patients of all types can be seen appropriately and have clinical evaluation, and especially if you think in the overnight hours when, costs are exceptionally high and access is particularly limited.
As they say, people don't only get sick between 9 and 5, right? I wanted to talk a little bit about FQHCs as sort of innovators. I had I'll never forget somebody I met who was sort of a very a thought leader really in the value-based care movement here in New York. And I remember he told me this was somebody who had access to very, high levels of insurance, commercial insurance. He sought out his care at an FQHC intentionally. The coordination that he was getting, this is somebody who is sort of a very big proponent of value-based care. It was, it was coordinated. It was efficient. He was getting the follow-ups. He was, they were coordinating through different services. It was kind of that model of integrated, coordinated care that, the private system, if you will, has been trying to create, and it somewhat exists in FQHCs. And so I was just, curious. You talked about telemedicine. Obviously, that's another place where, we've had innovation for a bunch of reasons, and now we can learn from that. Why, are we learning from FQHCs in terms of best practices? Can we be learning more? Why aren't we learning more? It seems like there's some really good models of what that kind of level of coordination can look like to help people overcome challenges and get the care they need. But, are we learning enough from FQHCs?
I mean, not just because I've made my career in community health, do I think you're exactly right. I think with an objective lens on, your local community health center is likely a one-stop shop. It's organized that way somewhat by design because the community-based patient governance of the FQHC ensures that the organization is being really supportive and is engaging in the kind of activity that the community itself actually needs. They're doing the local needs assessment, and they're not making their care deployment decisions based on, we can get reimbursement of X number of dollars if we have a 64 slice CT scanner. They're making their investments based on saying, wait, the epidemiological data show that 40% of our community faces hypertension. So we need to add cardiology and nephrology into our scope of service to keep our patients healthy and to make sure that we're addressing all the causes of hypertension and bringing the average blood pressure down in our community. Not even to mention the integration of behavioral health and dental care, which, the other great outcome of COVID is people checking in on one another's mental health in a way that never existed prior to 2020. I remark all the time the number of people that we come in contact with every day who are just checking in with each other in a way that was quite rare, in fact, before the pandemic. And, this, I think, has highlighted behavioral health for medical providers, for internists, pediatricians, family medicine docs, and the APPs who surround them in a way that's just totally different than it was before. And then, dental care has always been at the forefront. So many areas of oral health actually affect physical health, that having a dentist dental capacity on site in the building and able to be seen same day in case of need is really important. Often, dental issues are one of the top 10 diagnoses taken care of in emergency departments. And, that's something that more clearly regular maintenance care can be really important in improving.
Dental and mental health, Rob. And I know you're working a lot in that space around trying to bridge behavioral health and hospital systems. So, what's your take on that?
Really, I think you bringing in the innovation and getting to the behavioral health side. There's a lot that others in the healthcare system can learn from FQHCs on what the innovation is, and not just looking at FQHCs as the clinics in the community, but really looking at a center for innovation. I was talking with someone who was a national expert in patient engagement, and his view was the innovators in patient engagement are actually FQHCs. He's seen far more innovation there than he's seen in hospitals and health systems, and it was an interesting take on it. And behavioral health is a great example of that innovation, is truly integrating primary care and behavioral health. We tend in healthcare to silo patients by diagnosis, and nobody comes with a single diagnosis. We all have multiple issues that we present with, and frequently there's behavioral health issues that go along with that. And looking at that patient from a whole patient perspective and treating both the immediate emergent need, but also what might be underlying and going on with the patient, and integrating behavioral health with regular care is vitally important. And hospitals are doing a lot of that work. And I think more partnership with FQHCs makes a lot of sense in that, because there's expertise that the FQs have in behavioral health, certainly, in areas like Warren mentioned, in dental, and even in labor and delivery, which is a core and obstetrics is a core service that FQHCs have, and there's great opportunities for that integration and innovation.
I guess maybe, what gives you hope? Where are the opportunities for greater alignment, I think, is really the question I want to ask here. Is it data? You talked about aligned incentives, so obviously money is important, but what else needs to happen to create this kind of alignment? Is it technology? Is it data? What else could it be there?
I know it's not just money, but frequently that's the driver.
Right.
And interesting that it might be the lack of money going forward, as you talked about before with Medicaid, that might actually bring the FQHCs and the hospitals together, because they're both having to take care of the population of patients. It's going to become more difficult potentially to do that. And it may, hopefully, my hope in this is that it can bring them together to say, okay, we have a community to care for. The patients have needs. They're coming to us regardless. Let's work together to figure out the best way to provide that care. So, I think it comes down to the financial, but it also comes down to just that core mission of serving the community and serving the patients. And if we can get those aligned, the financial incentives with the core mission that they both have, we're moving in the right direction. Warren alluded at the beginning to innovative payment models. So the CMS Ahead model, which is a global payment, which means hospitals would receive a global payment for the community as opposed to on each episode of care. That hopefully will drive the hospitals to look at, what are my community partners, because we need to distribute that. There's also a team model of certain diagnoses now that Medicare is paying a bundled payment for, regardless of what services there are. So that'll lead the hospital to go outside the walls and say, I need to partner with others so that we can deliver this care in the most efficient manner, but also in the highest quality, and make sure that patients recover and stay well and don't come back to the hospital. So I think there are financial models that are beginning to bring the pieces of that together. The hope and the fear of it together is we tend to have models and we don't follow through on them. Hopefully some of these get followed through and continue on.
I agree. I think there's just a couple of areas that we could expand. That includes the regulatory framework. So much of what happens in healthcare is not allowed to be sort of satisfied by a partner from a regulatory perspective. I think if we can get to a point where you have a We talk about the team-based model of care inside the walls of a healthcare provider. Well, there's a team-based model of care that unifies all kinds of different providers within a community. And we need to have or figure out the regulatory structure that protects patients, protects providers, but also lets people truly work together to integrate data and use the tools at our disposal to make sure that we're hitting that right care at the right place at the right time. And someday soon there will be a good chance for AI, I think, to play a role in this too, especially helping us do sort of retrospective review to tweak and improve our systems development. So often, regulatory compliance becomes the hammer that prevents innovation. And, we must take advantage of an opportunity to remake the regulatory structure in a way that fosters the collaboration and in a way that allows all provider organizations in the community to be an extension of one another within a system of care. I think when we start getting to that, the promise of data liquidity and data fluidity over time. I mean, we've been talking about this since the late 1990s and getting the data in line. And now we have what's bigger than a terabyte? We have tens of thousands of terabytes more data available to us, and still, I don't think we really know what to do with them to make the life of a patient better. Sometimes there's some great examples of discharge data and things like that. That's a good flow, but we're living under a mountain of data that so far is not helping most patients get in and out of systems faster and with more efficacy. So, and a lot of that is because of the regulatory environment, where every time you walk into a different tax ID number, you have to sort of re-register and establish everything together, and we don't have the navigation tools available to us to help us, yet take a file from the hospital and transfer it to the FQHC to send it to the lab to go over to the radiologist. So someday we'll get there.
If you had a magic wand and you could redesign one aspect of sort of how these systems work together, or rather maybe don't work together today, what is the thing you would change first, and how do you think that would transform care for patients?
I would start with the incentives. I change the incentives instantly to make sure that all the different sectors of care are sort of required to integrate and work seamlessly with one another, and that there would be incentive penalties if they didn't.
And I would agree that it's driven by the incentives, but it's really making sure those incentives reduce the friction in our system. And it's just friction that providers have within the system. It's friction that patients have to access the system. If you think about what it takes just to get an MRI, and what insurance companies have to do and how much money is spent on that, and doctors have to do and patients have to do, that's all cost. That's all barriers to access. We got to reduce the friction and get the care of the patients going back to the beginning, the right place, the right time, at the right cost. But it all starts with the incentives, and the incentives come from how you pay for healthcare.
Oh, that little thing, how you pay for healthcare. Well, I appreciate both of your time today, and really appreciate the work that you're doing, and sort of the partnership that you're building is really a model for how systems should work. We're sort of building it internally and reflecting it externally in the work that you do. So I appreciate you both very much. And thanks for being with us today.
Oh, thank you.
For the chance to be with you.
This episode of Vital Viewpoints on Healthcare is sponsored by HMA Information Services. HMAIS is a subscription-based service that provides state-level data on publicly sponsored programs like Medicaid. From the latest managed care enrollment, market share, and financial performance data to up-to-date RFP calendars and state-by-state overviews, HMAIS has all the information you'll need to power your initiatives to success. This podcast was produced by myself, Jennifer Colamonaco, along with Tiffany McKenzie, in collaboration with our guests. The content is the property of Health Management Associates.